Okay, sir. Thank you.
Hello, good evening. First of all, I think I would like to thank Dr. Vidya for this very lucid presentation. We learned a lot. Thank you so much for accepting and doing this, Dr. Vidya. It was very insightful, and the key message of percentile wise, the way we have to look at the each tumor and ancestry based differences in TMB estimation is very new. I think that's a great learning even for me and for all of us. So looking forward, I think if at all you're unable to join, but I will uh, collect the questions if at all is anything is there from the participants and share it with you. And I hope you'll be kind enough to respond to that.
Yes, definitely.
Sure,
I would love to do that, interact with everyone
sure.
at any
Th-
point in time.
yeah.
Thank
Thank
you.
you. But thank you so much, Dr. Vidya. It was very helpful. Thank you.
Thanks for this opportunity, Dr. Arun.
Sure. Thank you. So next, I'll just move on to the next session. This is going to be a great session from an outstanding team from Turkey. So I love to invite Dr. Nalan. She's a very respected medical oncologist with over 20 years of both clinical and academic experience. And she is currently working as a consultant at Medicana Hospital, and she's been part of many early stage clinical trials also, phase 1 to 3 trials. So and her particular interest is in immuno-oncology, precision medicine, and she focuses on lung, breast, GI, and rare tumors. And she's got some fantastic publications with over 60 numbers in very leading peer-reviewed journals. Then we are going to also from the same group have Dr. Eylul. She's a molecular biologist and a specialist in companion diagnostics, again from the same center, Medicana in Istanbul. She is having a very unique expertise in interpreting genomic profile data, all these comprehensive genomic profile data that we get from NGS and making clinical sense out of it. So she would be able to get in all the relevant genomic markers and their insights and how they are applicable to the response to therapies and get evidences for it. So she is one of the key members who is organizing the tumor boards in that institute, in that hospital, Medicana. She's got a lot of publications, and I would definitely encourage all of you to read this one particular publication on RAF1 mutated sarcoma. It was a case report, but a fantastic publication where you would be able to appreciate the how molecular biology and genomics really helped change life of a patient of sarcoma. On a personal note, I'd been to this center. It's led by Dr. Mutlu Demirai. I'd been associated with them for a while. They are one of the pioneers in precision oncology in this part of the world, and not just in this part of the world, across the world. So they have done, I think, last I knew, more than 2,500 or 3,000 genomic profiles they have done, and they run molecular tumor boards on a daily basis. Each of their patient undergoes at least 2 to 3 molecular tumor board sessions during their course in that, and I have had the opportunity to be part of their molecular tumor board when I was there. So they have really changed many lives there. So with this background, I think we are fortunate enough to have them here, and I would request both Dr. Nalan and Dr. Eylul to take over now. Thank you so much.
Thank you. Will you present our
If you want, we can do that.
presentation, or
Yeah.
should we?
If you want, you can do that before, because you might want to change
Yeah.
the slides as per your talk. But if you want us to present, let us know. We'll do that.
We can share. No? Yeah, we can share.
Sure, cool.
Yeah. Thank you for this nice presentation, Dr. Arun, and having us today this afternoon. I believe we have a distinguished audience there, and most of them are medical oncologists or fellowship members, or I believe some pathologists and some molecular biologists are with us, right?
That's right. Yes.
Hopefully, it will be beneficial for everyone. Today, we will talk about interpretation of comprehensive genomic profiling and N-of-1 therapies in precision oncology. So I will mention about some background, how we came to the from the classical oncology to precision oncology, and how we did the mind shift. So comprehensive genomic profile and NGS tests, which one and when, and how we are building our treatments, modalities, how we are deciding the combinations in precision oncology. Instead of, I'm not talking about a classical pathway of the oncology practice. And of course, we need to mention about the tier classification, ESCAT classification, and the N-of-1 trials. Lately, I will talk about the strategic recommendations about the precision oncology for everyone. And my colleague, Dr. Eylul, will mention about how we can interpret the NGS tests, and she will present some case presentations to understand in more detail. So I would like to start with the central mantra of the precision medicine, delivering the right drug to the right patient. Actually, we can add the right dose with the right biology at the right time. So this is the central mantra of the precision medicine. Before, I was using this slide for the precision, my precision talks. I was saying current medicine is one treatment fits all. So the future medicine is more personalized, diagnostic, and treatment modalities. Just that last week, after seeing this comment, I'm strongly advising to read for each of medical oncologists and
Dr. Nalan,
yes.
sorry to interrupt. I think the slides are not moving. We are still seeing the first slide. Maybe you can go to the presentation mode and share this.
Sorry, let me try. Slides.
Or you would have shared only a window rather than the entire screen.
I think we shared the window. So sorry, I'm going to try to restart with a different setting, I guess.
Yeah, you can share the entire screen. And then when you go to the presentation mode, it comes up.
No, it's the background to background. Yeah, to background. Yeah, okay. Let's do the whole screen option. Yeah, that should work better, maybe. Does it change now?
You're in some publication.
Yeah, okay, yeah, that's true. Okay, then it is changing.
Is it changing?
It is changing, but on the right side, we are seeing
a small thing as well.
I see. Full screen.
Yeah, it should be that way.
Is there anything change?
No, we are seeing only the file, not the presentation mode.
Yeah, because it's just
Can you open from your side? Maybe
I think, yeah, I'll do that. I'll just ask the team.
Just computer is not responding as well.
Okay. No issues. Mirai madam, or anybody from the organizing technical side, can you share the screen?
Yeah, we can share the screen. I'll ask them.
Yeah.
Office kullan. Double screen game. Kapatayım. Ekranı. Öbüründe de.
Yes, now it's in the slideshow mode. Thank you.
So
Yeah, I think they started sharing the screen from the admin side.
Okay.
When you want to change the slide, you can just make a request.
yeah, can we move? Yeah. So I mentioned about the central mantra of precision medicine, and then yes, we can move to the next slide. Yeah. Current medicine is one treatment fits all, and the future medicine is more personalized, should be. And next. And I mentioned about the new comment, which written by Vivek and Razel Kurzok. They are stakeholders for precision oncology. So I decided to change my slides. Next one. Yes, it's written that the ability to tailor therapies to individual patients based on their unique molecular makeup is no longer a distant vision, but a reality. So it's not a future treatment, it's a reality. So we have to be more careful about whatever we are talking about for the precision medicine. Next, please. This is very typical example in 2022. Everything changed in whatever we know about cancer, because GIST tumor, it was known as untreatable bad prognosis sarcoma. It's treated by the imatinib easily. So one patient's fate totally changed after these medications. It was the one of the most audible targeted therapy for the medical oncology side. And then something changed in the molecular side. Next, please. Human Genome Project was the most important part of the diagnostic. So we know whatever we have in our genome, human genome, and especially for the cancer patients, tumor genome. So we had some new information to use in clinical practice. Next. As you see, the human genome, including just 22,000 genes, and a few hundred are known to be involved in cancer. And in our analyzers, generally we are 300 to 1,000 genes we are investigating for learning about the cancer biology. This is what is a comprehensive genomic profile exactly. Next, please. Of course, in the laboratory side, something changed over the time very quickly. It started with the immunochemistry. Can you see my? No, okay. So immunochemistry, it started with immunochemistry. After that, FISH came out, PCR, Sanger investigation, and then NGS-based hotspot testings were the new modality. And after hybrid capture is possible, so we had the chance of seeing whole genome or whole exome analysis in one test. And we were able to do in a one time and multiple genetic investigation in the same time. Next, please. So the three different things developed in the same time. One is in the laboratory, some investigation methods are developed very quickly. The other thing is in the tumor cell, the molecular pathways became more clear for us. What is the between all the pathways, which molecules are working, we understood more in detail. And the other side, in the clinical side, we decided to combine this information all together from the laboratory to the clinic. Next, please. First, in 2021, first time we talked about some tumor agnostic indicators, which one NTRK, MMR, MSI high, and high TMB. And over the time in 2025, as you see, more than 30 new markers are established, and now they are used to treat the cancer patients regardless of the tumor origin. Next, please. Tumor agnostic approach is totally new for the medical oncology because we used to approach the patients according to the organ-based cancer, colon cancer, and which even the right side, left side is new for us. Rectum cancer and colorectal cancer on the same basket, and we were approaching the same. Some patients getting some benefit from the standard care, some patients not. But as you know, we are not taking care of all the patients in the classical pathway. We have to treat the bulk of the patients instead of each of every patient, because we don't know each of every patient which kind of biology they have. And as you can see, for example, the red fusions, if detected in the lung cancer or the pancreatic cancer or the colon cancer, if you can target this molecule, you can see the benefit, whatever what kind of tumor origin they have. So if you find a target, it's pan-cancer target. It's not 100% is true, but generally we can use this one, right? Yeah, it's open. Next one. Yeah, another thing is happened for the BRAF V600E mutated tumors. We are familiar from the breast, the malignant melanoma, but now whenever we see the BRAF V600E mutation, we are treating in the same way. Next, please. I emphasize the tests NGS tests are very important to giving any decision in the precision oncology side. But which tests should be used? Everybody is very eager to use and develop new tests in their local laboratory and the governmental hospital somewhere. But of course, this test is very sophisticated, and we should trust the test first. It should be good, validated, and very open for the other authorities. It started with single gene test. We are familiar for EGFR mutation in lung cancer. We were just looking at one genetic abnormality, which is EGFR mutation. Now we are talking about more comprehensive genetic profile. Just one gene test is evolved to comprehensive genomic profile. Now this test has provided molecular diagnostic professionals a wonderful tool to explore, unearth the genetic alterations underpinning the pathophysiology of the disease. So just knowing the EGFR mutation is not enough for medical oncologists now. So we need more detail about the tumor. Thank you. The next. So it's a very sophisticated methodology starting from the pre-analytic period of time, sample source, tumor sample, and DNA extraction or RNA extraction. some analytic process, and of course, after the analysis, interpretation is the most important part. Half of the part from the laboratory, the other one is in the clinical side to understand which mutations are driver or which mutations are not driver or resistant, showing some resistance, and how we can help the patients. The next. So as a result, currently in the comprehensive genomic profiling, we need to see DNA sequencing, RNA sequencing, tumor mutation burden. Already you talked about the previous session, I believe in. Loss of heterogeneity and HRD score should be in the test. PD-L1, of course, and MSI should be included. Depends on the test modality. Some kind of immunochemistry test should be in the comprehensive genomic profiling. Now, currently, they are working on some immune scores. As you know, deciding for the immunotherapy, PD-L1 or MSI is not enough markers, and we need to use other scores. So immune score is coming nowadays. For the specific melanoma cases, we are familiar to some HLA groups. Some tests are reporting, and some gene signatures like smoking signatures or HPV viral signatures are also important to give our decision. The next. So this is an example of the NGS test. We can see the microsatellite in stable or stable situation, tumor mutation burden, low or high, HRD situation, or some scoring system, and pathologic or likely pathologic DNA abnormalities, and some HLA groups, which some of them may be important for some tumor site. Nowadays, just for melanoma, in the future, maybe for some other cancers, and some immunochemistry tests. In this test, ER and HER2 and folate receptor 1 is results are showing. The next. Another interesting thing is unknown primary cancer is almost going to the history, and we know now if we have a detailed genetic test, we can understand what are this cancer's origin. So depends on the RNA results. So we can understood in the whole pool, the data can choose which origin may show some RNA abnormalities. So even the cancer unknown primary is not unknown primary no more. Next, please. This is another example showing two tests together. You are seeing right side the liquid biopsy, and the left side you can see the tissue biopsy and at the same patient. This is breast cancer patient, and in the tissue we can see the PIK3CA mutation, and WAF value is 22%. Dr. Eylul will mention about the WAF, what is the WAF and what is the importance in the test. She will show us. And some somatic mutations are listed here, TP53 and PRIM1 and the others. On the other hand, in the liquid biopsy, we can see, along with the PIK3CA mutation, very important resistant mutation is ESR1 mutation is detected, despite the low WAF value. And HER2 mutation, a kind of HER2 mutation is there. If we just look at the tissue biopsy result, we can assume some PIK3CA targeted therapies. But if we see all, on the other hand, in the blood liquid biopsy, we will understand some other mutations, as is ESR1 and ERP2 mutations can be problematic for the treatment. So we need to understand altogether. If we have, this can be explained by the tumor heterogeneity. So if we are looking for the just breast tissue, we can see the breast tissue clonal and subclonal area. But if we can look at the blood, if shading enough, we can see from the everywhere different metastatic areas. From the different metastatic areas, we can see other mutations we can catch up. Next, please. Another thing is artificial intelligence became our part of life, starting from our computers and our cell phones. Now, of course, in the precision oncology, their part of working is getting bigger. Now, RNA-based some algorithms investigating the patient's RNA results and some pathway, doing some pathway analysis and matching with some drugs available in the pharmacy. So this is not very mature and also not very common in the world, but it's coming already. So we wanted to mention about the next one. Yes, I give some smoking signature examples. So signature 2, 13, 5, and 4. All the signatures are related with the smoking. It can happen in the head and neck cancer, in the lung cancer, bladder cancer, whatever. But if we are seeing this kind of signature, it's smoking signature. So they are sharing some specific mutations in all the cancer types. Next, please. So our treatment evolution in the oncology from the organ-based therapy to the multi-omic data-based therapy. Multi-omic data is transcriptome, genomics, and proteomics, all of them. So now we have a lot of tools to decide more precisely. Next, please. In the precision medicine, we are sometimes advising some unexpected combinations. What is the rationale and the background? For example, if we are talking about the lung cancer and 2 different clones are in the lung, one of them can be give the response to drug A, but the other clone may not respond to drug A. And if we are seeing this progression in the other clone, we can try drug B, and we can get another response. But after that, other clones started to grow up. So at the result, we should combine these 2 because these 2 clones are totally different. And if we found the correct medication for these clones, we need to combine them for the best response. Next, please. This is very new sample for the 9-headed cancer Hydra from the mice, Greek mice, most probably. So we know that cancer is very sophisticated and more clever than us. This is very clear. And if we want to fight with the cancer, just cutting one of this Hydra will not get benefit. We have to cut all the heads at the same time. It means if we are facing with multiple driver mutations in the same patients, we have to block all of them in the same time. Otherwise, we cannot control the tumor. Next, please. So how we can trust some genetic abnormalities, which is important for the cancer or not important for the cancer, or some medications fitting with the mutations or not. So some classifications are raised. So tier 1 is the best one. Strongly clinical significance. This mutation has very clear, for example, HER2 mutation or EGFR mutation for the lung cancer. And we have a medication anti-HER2 or anti-EGFR, well tried on the clinical trials, FDA approved, everybody is agree. So tier 1 is the best quality of evidence actually. And the quality of evidence is dropping from the 1 to 5. 2 is potentially clinical significance. You found a mutation in the test, but you are not very sure about this cancer. This mutation may cause some abnormalities in the cancer, and what is the significance? Should we block this mutation or not? But clinical clinical potential it has. And the tier 2, 3, we don't know what is significance, and we don't know how we can approach this mutation. And tier 4 is totally benign or likely benign variants they are mentioning. Next, please. ESMO, European Society of Oncology, also took some actions in 2018, and they published ESCAT scale of the clinical actionability of the molecular targets, ESCAT. The theory is same, how we can trust the one abnormality, mutational abnormality, and medication or drug for certain circumstances, situations. Next, please. So ESCAT1 is alteration drug match is associated with improved outcome in clinical trials. FDA approved, everybody knows, and everybody is agree. ESCAT2 is investigational. Drug interaction drug match is associated with anti-tumor activity, but magnitude of benefit is unknown. Next, please. And 3 as alteration drug match suspected to improve some outcomes based on the clinical trial data in other cancer types. For example, you found in breast cancer, but it's already some publications you can find in lung cancer. So you are not pretty sure this mutation is very important for this cancer, and this medication will work like lung cancer. And 4 and 5 is depends on the preclinical evidence actionability. So you cannot trust this data, but sometimes we don't have any data in the tier 1, 2, 3. We have to look at some clinical preclinical evidence to understand this mutation or this possible drug is effective or not for certain patient. And 5 is alteration drug match is associated with objective response, but without clinical meaningful of benefit. Totally open and questionable. And X is lack of evidence of actionability. Nobody knows this mutation is important or not. The data is unknown. Next, please. NF1 trial is also new for us. We are familiar to phase 1 study, phase 2, phase 3, phase 4, but NF1 or case reports are not important at all for the medical oncology till now, because the treatment decision and outcomes are based on single patients, because personalized oncology medicine or oncology focus on only one patient's values are important. So this is an exceptional opportunity for fast tracking of cancer drug development in the precision oncology area. Because if you can find a benefit in even one patient, you can show them even a benefit in even one patient, you can go on very quickly, advanced clinical trials or advanced approvals. A lot of types of N-of-1 trials is possible. Generally, during this clinical trial, tumor tissue removed from the patients undergoes some advanced genetic investigation, including DNA and RNA expression analysis. Researchers are in a laboratory that then analyze the information. Sometimes they are doing some xenograft studies or cell culture investigation and deciding which medication can be fit for this specific mutation. This enables us to identify the distinctive master regulators that are required for the cancerous activity in the specific patient's tumor. So this is a prospective clinical trial, a kind of prospective side. On the other hand, on the other side, we have some case reports, which became more important nowadays because each of the patient's experience can be important for the others. So in our clinic, we have a lot of nice clinical presentation case reports we published, and I believe it will be helpful for the other clinicians and the patients. Next question, please. N-of-1 trials is a kind of shortcut from the preclinical data to the advanced phase trials and drug approvals. Next, please. And another dogma is changing, drug-centric model from the drug-centric model to patient-centric model. And I want to finish very important 5 strategic recommendations for the best precision oncology approach. 1, the reevaluate randomized clinical trials requirements in the lethal cancers. It's a kind of another topic to be discussed, but current approach is not very quick, and one clinical trial is resulting in 5 to 7 years, and after that, one medication can be available for the patients. So we don't have enough time now, and we have to find another pathways to get new approvals. Secondly, implement early molecular profiling and early matrix therapies. And nowadays, what we are doing, if the patient is advanced, taking the standard care of therapy, and then we are looking for some advanced genetic investigation. But it's too late because we know some driver mutations. If you are approaching them very early, the response rate is more than 70%, for example, MSI patients. But if you are postponing this approach to the third and later lines, you are not getting any benefit or very low benefit. So early molecular profiling, nowadays they are advising even before advanced cases. Yeah, I mean the early cancers instead of just advanced cancer. And we have to create a strategy for identifying and addressing pan-cancer, including N-of-1 studies and the case reports, etc. And tumor agnostic targets across all the potential markers and cancer we have to find. And alternative evidence generation methods should be found, and maybe we have to change some clinical outcomes threshold for the innovation. And as we know, in the colon cancer, third line regorafenib is just benefit is 1.4 months, and on the other hand, gefitinib got approval for the pancreatic cancer, just less than 1 month survival benefit. So significant and statistically significant is not clinically meaningful. And after the precision oncology develop, we need to look at again all these thresholds. And of course, we need to create supportive regulatory frameworks in the laboratory, in the government, and agencies at all. Next, please. Some bullet points I want to emphasize here. As we talk about, specific survival thresholds should be clear or should be changed in the future. We need to accept as an evidence, scientific evidence, phase 1 and 2 trials and real-world data as significant, sufficient justification for the treatment change, not just randomized clinical trials, but also phase 1, 2 studies and real-world data. We have to keep in our mind ineffective therapy, despite it can be a standard care. Ineffective therapy may increase tumor resistance and even an active therapy. So if we are closing our eyes and giving the standard care, some of the patients are not getting benefit. Instead of we may give harm to patient, causing some tumor resistance. And approximately 30% of all FDA-approved anti-cancer therapeutics are prescribed off-label. So off-label usage is not the rare state. We should use more logically. Another important thing is what we are doing here is training physicians in the molecular oncology, and clinical trial design is vital. I'm experienced medical oncologist till the last year. I barely aware of the precision oncology details. After involving with this team, my thinking style or looking at the patient's result totally changed. So it's a kind of a mind shift, and it should be supported by the specific training, which is not currently very clear, like fellowship program or others. And we should create living guidelines, not monthly or longer period of time changing, rapidly evolving discoveries. And we must embrace innovation rather than repeating the same approach and expecting different outcomes. This requires openness from the reviewers, regulators, funding agencies, and researchers and institutions. Next, please. So treatment evolution from the evidence-based therapy, going to the science-based therapy. What is the science-based therapy? It's more flu era. So this is what I want to say today, and this is our distinguished team photo. Next one. Yes, this is our precision oncology team. We are working with 6 distinguished molecular biologists here and 3 doctors. If you have any question, I would like to answer. Thank you. Or we can go ahead with Dr. Eylul. She will present some cases, and she will mention about how we can interpreting the tests in the NGS. What would you like to? Shall we go on?
I think we can go on with Dr. Nalan's presentation, and we can take the questions at the end of it if it's fine.
Yeah.
Would you mind if I try to share the screen again?
Sure,
Because
please go ahead.
before making up it's fixed, because I would like to use my
Sure.
laser.
I couldn't use.
Okay, let me see. So sorry.
But audience, if you have any questions in the meantime, maybe we can use this time also for any discussions. Okay, I think it's up. Yeah.
Okay, I think it's working now. Do you see the whole screen?
I do, yes.
And it is changing?
It is, yes. And
Yeah,
you're clear.
because it was connected to TV before.
Good job.
Okay. So hello everyone. Thank you for having me in this meeting. I'm very proud to be part of this. as Dr. Umar also mentioned, I'm a scientist, so I'm not an oncologist. I'm going to talk about how we interpret CGP reports, how we evaluate our patients from a more molecular point of view. And because interpretation of such tests, I think, requires some understanding of how a cell works and how it got diseased, you know? So our approach, we use a large panel here for every patient. We prefer a large panel, not just to catch multiple mutations in multiple genes. Yes, that's very important, but also because some biomarkers, such as tumor mutational burden, is only meaningful if you have more than a certain number of genes. That's around 150 genes. If you have less than 150 genes, your sequencing, the TMB tends to be less accurate. You're going to undermine, or you're gonna think it's higher than it already is. That happens in liquid biopsies, especially. But we here prefer very large panels, and we try to evaluate multiple biomarkers, non-DNA biomarkers as well. So just quickly, I want to mention about the difference between a whole exome sequencing and whole genome sequencing. Maybe these are already been mentioned in the previous sessions. I'm not really sure, I'm sorry. Just a quick recap for that. So whole exome sequencing, we are interested in the protein coding regions of the DNA most of the time. Some intronic regions and some regulatory regions like promoters can be included. One of the things that is done better with whole genome sequencing is that these regulatory regions or introns can be quite important, especially for finding translocations and structural rearrangements. That means actually fusions, finding novel fusions, kind of requires a whole genome sequencing. So, but both can be used most of the time for clinical oncology purposes. But I think mostly now, including the specific regions of interest in WES, is quite common. So just a little bit of the basic structure, basic anatomy of a gene. You have a regulatory region. That's not just the promoters. Promoters is one of them. You have also regions that regulate the transcription of a gene. One of the drawbacks here is that we are not really looking at those regions right now because we don't really know.
Dr. Nalan? Sorry, Dr. Eylul, sorry, your voice is a bit fading away. It's coming up and coming down. I think you need to come a bit closer to the mic.
Yes, that happens true. Sorry, is it better now?
It's much better now. Yes.
Okay, sorry. So the regulatory regions are involved in the transcription most of the time, and we don't really know how they translate to the clinic. But we know they're pretty important actually, but we just don't know the clinical importance. Maybe that's some kind of a future region for oncology. But we have to know about the transcription, that we have this RNA level sequencing is also super important. I'm going to mention the fusions. And then from the RNA, we got the translation and the proteins. Proteins, we are most interested in the proteins when we are talking about the cancer. Actually, yes, we are looking at the genes and the changes in the genes. Well, what is the outcome of this? So it's the protein. How does the protein changes? Does it activate or does it get inactivated? And one of the things that we maybe should really consider is that a gene can have multiple protein products. That's there are several mechanisms like splicing, and that might be actually relevant for cancer because some tissues tend to express more of a certain isoform, while the other one wants to expresses another. That happens with AKT, for example. Probably why AKT1 is quite important in breast cancer, and now we have the drug capivasertib for that. It's expressed quite a lot in breast tissue, but other AKT isoforms are expressed in other tissues more dominantly compared to AKT1. So isoforms are also kind of less studied field, but could be important. So our clinic really, we obsess over the proteins and their domains, functional domains, because we tend to get a lot of unknown mutations here. Like there is a mutation, it's not very well characterized. So we look at the protein. Proteins have distinct domains that are functionally distinct. And there are regions where mutations tend to occur frequently. That's like hotspot mutations, as you know, in TP53 as well. So the left one is a CTNNB1. This protein is an oncogene, and we see that the mutations here, these are all the mutations, they accumulate in this domain. This domain is involved in the degradation, for example. All these mutations results in accumulation of beta-catenin in the cell, which shows some oncogenic activity. And these are the gain-of-function mutations we usually say for proto-oncogenes. And the loss-of-function mutations we talk about a lot. That's for tumor suppressors mostly. And tumor suppressors, when you lose the function of a tumor suppressor, it kind of acts like a brake for the cell. So you lose a brake and you start to go faster into the root of a disease, of tumorigenesis. One thing about P53 specifically, I put it here, is that there are some dominant negative mutations. These mutations look like they are actually gain of function in the sense that it disrupts the way P53 complex work. So there are some subtle differences in how a protein can act in a different way with a similar mutation, let's say. So this is, I want to mention some of the things we use quite a lot in our clinic. This is from a test as CGP. So we see the protein and DNA alterations. And for proteins, if we get like an uncharacterized mutation or a VUS, we recently had a patient who had a VUS in mTOR and nothing else. Actually, the patient had an extremely good response to an mTOR inhibitor. And we came to that conclusion by analyzing the structure of this protein plus using some tools that are already available. So when you see these unknown mutations, we look at the protein, look at the domains, we use the existing knowledge, and we use some tools to predict the function. So for this, we use a lot of PolyFem2. These are prediction tools. AlphaMissense is a new one, very good one. And SIFT, there are many others. So we actually use these tools in combination because the gold standard is to do an experiment. But if you can't, and the patient has no other options, let's say, and you are really, the frequency is high and the expression is high, and this mutation is actually lying in somewhere functional, it looks very suspicious, then we use the combination of these tools, and if they all predict a similar outcome, like it's pathogenic, sometimes we actually think about it in the therapy, actually, as a target. And for DNA, I use myself a lot of CCDS. CCDS is for cDNA sequences, and you will see there are multiple transcripts there you have to choose. If you ever need to look at the cDNA and find the amino acid corresponding to a specific region in the DNA, in the cDNA, CCDS is one of the best, I think, easier to use databases there. So variant allele frequency, this it means that when you sequence a sample, you find a certain mutation in a specific frequency. That is what it is. So you see that in 20% of the sample, there is this mutation. This doesn't mean that the 20% of the cells have this mutation, because it may mean that. But it's a bit tricky because the copy number alterations changes the outcome. So it's like a single cell may have a mutation plus an amplification of the mutated allele. So you will see a higher allele frequency that is coming from a few number of cells. That's possible. How we use it is it's also a little tricky. We had a recent conversation with a huge CGP company. It's not so easy, or let's say it's not so accurate always to interpret the allele frequency. One of the things we emphasize is that, of course, if it has a really high allele frequency, genetic alteration, it might be a germline alteration, but that must be tested again with a specific germline panel. We always recommend that because the tests we use for CGP are usually not validated for germline alterations. If it's above 50%, it might be. But most often it's not germline in my experience. Another thing is that a high WAF score can indicate a clonal mutation. That may be present in the primary tumor. It's going to be present in the most metastatic sites. It's not very likely that the tumor will lose it over time if it doesn't confer a fitness advantage. For liquid biopsy specifically, they use WAF scores for follow-up actually to measure the tumor burden. But this is also not going to be super accurate because how much WAF score you get is going to be based on the shedding in liquid biopsies, and the shedding rates might change depending on many factors. Overall, we think that a high WAF score, we should treat these alterations, we should think of them as a clonal alteration most of the time. And there are subclonal alterations that have lower frequencies that will actually indicate the tumor heterogeneity, that there are newer clones with new novel alterations. So we use the WAF score for that basically, and to understand the heterogeneity. And sometimes it is used as a treatment option. Because there is this notion that if the alteration has a higher WAF score, we should target that. That's probably true, but that is just not clinically proven yet, interestingly. Dr. Nalan already mentioned this one, so I'm going to skip this. So, CGP for diagnostic importance. I want to give an example of a patient. This is a patient that we have. He has a TERT and TP53 mutation. This patient came us with a cholangiocarcinoma diagnosis. And then when we do the literature search, we found that in the hepatocellular carcinoma and cholangiocarcinoma landscape, the TERT mutation is almost never seen in the cholangiocarcinoma patients. And rather, the combination of TERT and p53 is very common in the hepatocellular carcinoma. So then it came that there's not a new, but a rare pathological condition that is the mixture of hepatocellular carcinoma and cholangiocarcinoma. So these alterations being together actually shifted the diagnosis from cholangiocarcinoma to hepatocholangiocarcinoma. Plus, this patient had alcohol in the cirrhosis, so it was very likely to be stem from hepatocellular component. The thing is, this is quite important for treatment choice because in these patients with a mixed histology with a hepatocellular hepatocholangiocarcinoma, it is better to follow the hepatocellular carcinoma treatment. So this patient received a standard treatment in the first line, and in the second line, for example, lenvatinib for hepatocellular carcinoma is currently being evaluated for this patient. Another diagnostic information can come from the signatures. So signatures we already mentioned, but signatures we can find with a large panel of NGS, and they can be quite important for diagnosis. This patient we had, the patient came us with a head and neck squamous cell carcinoma. but had an unknown primary of unknown primary. And the RNA actually said it's bladder or urinary tract. That was quite interesting. But then a pathologist told us that they found a UV signature. This UV signature, with the clinical data we have, the site of the metastasis is the parotid gland, said that this is very likely to be a skin squamous cell carcinoma rather than a head and neck squamous cell carcinoma. So there was a previous case very similar to this, could be an UV-induced TMB high situation there as well. And this patient, so now is going to be treated based on the skin squamous cell carcinoma rather than the head and neck, because this UV associated signature, there are multiple studies supporting this diagnosis. Another thing is the allelic status. So mutation can happen in a single allele or can happen in both of them. And that is quite important for specific alterations. And we had experience with both of the examples I'm going to show you now. So, for example, EGFR mutation. So you start, first, the patient is newly diagnosed as a single EGFR mutation. You start with a first generation anti-EGFR, and then you get T790M, you start osimertinib, and there's another mutation that causes resistance to osimertinib, that is the C797S. This is a tertiary mutation that interferes with the binding of osimertinib to the protein, so it's a resistance mutation. So it's very important whether these mutations are on the same allele or this we call a cis relationship, or are on the different alleles. So this is a trans relationship. Because if it's on the same allele, there will be two mutations in the same protein. But if it's not, there will be only one mutation in one protein, and the other protein expressed has another mutation. If they are on the same allele and the same protein, then osimertinib won't bind here, and your patient is not going to respond. That's exactly what happened in this patient. And in this patient, you have the treatment approach for like brigatinib. Brigatinib can bind to EGFR, and brigatinib doesn't really interact with this residue. So unlike osimertinib, it's a smaller molecule. It doesn't interact with this amino acid residue. Therefore, it actually has inhibitory effect. And we saw response from the patient for like 6 months. I think she had the regression. If it's on a different allele, then you can actually go on with osimertinib. This is one of the most prolific examples of the importance of allelic status. Another thing is the PI3K-CA mutations. If you have double mutations in cis, so they're on the same alleles, the patients actually respond better compared to those with a single allele mutation. So it's quite important to know whether your mutations are in cis or trans, because if you have two mutations but they're in trans, you're not going to see this kind of increase in the response. And how you know if it's cis or trans, you have to ask the company. Right now, we don't have a direct way of seeing it on the test results that are given to us. And lastly, this part for RNA and RNA sequencing. That's the golden standard for detecting fusions. It's better than DNA, technically. And it's also better to understand if a fusion is actually transcribed or not. Because a fusion in the DNA may not be transcribed to RNA at all, might be out of frame, and might not be reported. But if you find the fusion in the RNA, that's very likely to be functional. It's already in the RNA, so it's in the frame. So it's very, it should be taken seriously when deciding treatment. Also in DNA, of course, but always a question if it's in frame or out of frame. Could be also hard to detect it with genomic sequencing. So this was the first part. Do I still have time, by the way, or are we running late?
No, we have another 10 minutes. We can.
Okay, 10 minutes. Okay,
Yeah.
cool. Okay, so the second part, I prepared 2 cases. One Dr. Umar already mentioned, that's about the rough one. That's the second case. So the first one is a pancreatic cancer patient. So this I put because I think it's very interesting that there's a subclass of pancreatic cancer patients that can respond to targeted treatment. And this is something so easy to miss for, I think, many clinicians, maybe because the alteration is kind of rare. So this patient, quite old, actually 73 years old, and he was diagnosed with the liver metastasis, and he started on gemcitabine but progressed. We did a liquid biopsy for this patient, and the liquid biopsy showed an alteration in BRAF. So this is not a V600E mutation. This is a very unique mutation in BRAF that we encountered for the first time. So while, look at it, I mean, the cfDNA is very low, but the patient had enough tumor fraction. And when there was enough tumor fraction in liquid biopsy, the driver alterations tend to be correct and accurate. So if this is a BRAF alteration, we were very interested because we already know that there are different types of BRAF mutations, class 1, 2, and 3. And this is now very common. This was not very common when I first started. But now BRAF mutations are grouped in 3 classes. The class 1 is the V600 mutations, very active, usually monomeric, can be dimeric, and they have their own inhibitors. And the class 2 mutations, these are also activating mutations, and BRAF fusions are also here. The difference is that they are a bit less activating. One of the main differences is that the monomer inhibitors don't really work here, especially vemurafenib, because these require some dimerization. And the class 3 is very different because these have less activity or no activity at all, and they tend to respond to upstream inhibition. So then we looked at the pancreatic cancer without KRAS mutations. So the thing is, 85% of pancreatic cancer patients have a KRAS mutation. So this was a very rare find. And then when we look at the landscape of those patients, we find that the most frequent mutations are P53 and in BRAF. So these patients already showed some consistent genomic profile with the literature. Then they showed that in patients, in pancreatic cancer patients without KRAS mutations, the BRAF mutations tend to cluster in the kinase domain. And this mutation here you see is the one that our patient has. This is a deletion of 5 amino acids, and it's going to result in activation of the protein. I'm going to show you. So if you have KRAS wild-type pancreatic patients, it's very likely that they're going to have a mutation in the MAP kinase pathway. 44% is observed. So among this 44%, 24% will be BRAF alterations, which are possibly going to be targetable. And in this case, I think if you have a KRAS wild-type pancreatic patient, it is kind of a luckier situation for the patient. And there were some studies, just going to say the result, that this mutation was actually activating, and this deletion results in the activation of MEK and ERK, the downstream targets of BRAF, and were resistant to vemurafenib, but were sensitive to a pan-RAF inhibitor. The mechanism is very similar to EGFR exon 19 deletions. This is already a very conserved mechanism for almost all the kinases. You have this structure here that keeps the protein inactive. To get activated, this loop you see is going to get shortened. So this is the normal protein in an active status. It's just got the loop shortened. And when you have a deletion, it shortens this loop automatically. So this deletion occurs in this region really, and it does get shorter because it's deleted now, it's shorter. So it's always active. It's the same thing with EGFR. And based on this, we checked some preclinical data. There is preclinical data. Dabrafenib and trametinib seem to work the best. And some case reports, actually. That's a relief, not to just go on based on the preclinical data, but it was good that there were actually case reports about this, that the NV-type deletion, the same alteration, one study did dabrafenib, and they saw a response, and another study did dabrafenib plus trametinib. And we thought MEK inhibition is quite important in type 2 BRAF mutations. And based on these case reports, actually, they are quite consistent with the preclinical data. We decided to also go with the combination. And in the first week, the patient actually started to feel much better. In the first follow-up PET-CT scan, the patient showed almost a complete regression. And it's been 9 months. The patient is just taking the combination treatment with no progression and good performance status. So another case is about a RAF mutation. This is also in the MAP kinase pathway, very similar to BRAF. It's CRAF, actually. So this patient has a myxofibrosarcoma and actually completed all the things that she could have. We did the CGP, and we found this RAF1 mutation, also with a p53 and CDKN2AB loss. And based on this CGP result, this just to show that she actually really exhausted all the options. This is again in the CRAF, just like BRAF in the MAP kinase pathway, especially very prevalent in the RASopathies and some congenital diseases. And we know at this time that the RAF1 fusions that are activating in cancer can respond well to trametinib. This mutation was quite unique because this specific mutation was not in the literature. It was not reported before. So what we did was to look at the wild type function of this amino acid, the S259. And when we look at the wild type, for the wild type protein, this position is quite important because it keeps it inhibited. So if you change the amino acid here from serine to some other amino acid that cannot be phosphorylated, the protein tends to get activated. It prefers an activated conformation, let's say. So based on this, we actually collaborated and did a very quick Western blot experiment with a laboratory, and they showed that this specific mutation that our patient has actually has some activating effect on ERK, and even higher than the positive control. And then we also simplified the mechanism here that if you lose this amino acid, if it's changed to proline, as in this case, it loses a phosphorylation, that is a post-translational modification, and it's primed for activation. It's the conformational change actually primes it for activation. And decided that we hypothesized first that it's always active, and then we quickly showed, of course, can be shown in more elegant ways, that it's an active protein. And based on this, we decided to start with a MEK inhibitor. We don't have a CRAF inhibitor other than the pan-RAF inhibitors, but they are all multityrosine kinases that can have some other off-side effects. And the other thing was, should we go with the combination because the patient had a CDKN2AB loss? And this study, small study, put a rationale for combining MEK inhibitors with CDK4/6 inhibitors if you have alterations in the both pathways. So there were some prolonged responses. Also, this patient being a sarcoma and CDK4/6 inhibitors has some, actually one of the better tumors that it works because CDK4 expression can be predicted for these patients. So we decided to go with the combination actually because this RAF1 was so novel we were not really sure if just a trametinib will be able to control the tumor, as the patient had a very aggressive course of disease. We did the combination, and in the second month, this is the first follow-up, again, we saw almost complete resolution of the tumor. And the patient has been going on with this combination for 3 years now. So I think this is just great to show that finding this kind of novel alterations and targeting the correct protein can result in amazing results, even in heavily pretreated patients. We also follow with an MRD, so from the blood with the ctDNA, and she showed no sign of disease in the MRD as well. And that was all for me. Thank you. And if you have any questions for both of us, also for Dr. Nalan, we are happy to answer.
Well, thank you so much, both of you. I think it was very interesting and enlightening. The two cases were quite inspiring. The level of depths that you go at the molecular level to understand the genetic variances, it's great, actually. I think kudos to the team. Just maybe before I ask, is there any questions from the audience? You want to ask any specific questions?
Okay. Thanks, Arun Kumar. Thanks both of you. So it was a wonderful presentation. Actually, I have 2-3 just concept-wise queries. Like as a medical oncologist, most of the times we are all like we practice, as you said, evidence-based medicine, where we always look for clinical trials. What is the evidence? What is the phase 3 trials, phase 4 trials? That's how we all practice. So now the problem with the precision oncologists is we don't have data. Many of the time we need to mention it's unlabeled data and we need to progress. So you nicely said that when there are a lot of driver mutation, you need to cut all the heads together. There's no point. That's nice concept you said. But many times what we find is when we combine drug A and drug B based on these driver mutation analysis, is a toxicity that is a problem. We don't know how the combination acts. We don't know whether that is the main pathway, because you can see that trastuzumab works so good in breast cancer, but the same trastuzumab when used in adjuvant setting in stomach or any other cancer, it didn't work. Trastuzumab, pertuzumab, lapatinib, which means that there are other pathways also is there, or downstream pathways. Probably that's why it's acting so good response we had in breast, but we didn't have the same response in other cancers. So in this situation, like how did you start your practice based on these mutation? What is your experience in combining the standard of care along with the other drugs based on the driver mutations? What about the toxicities that we fear, because we don't have data when we combine different drugs based on the mutations? How did you manage all these things? I just want to know your experience.
Yeah, thank you for this interesting question. It's very important for the practicing doctors. Everything is very fancy, the new medications, new modalities, something else, but at the end of the day, we are facing with the patients and the toxicities. So theoretically, cutting all the heads of Hydra is not easy, and we don't know this mutation is one of the Hydra's head or not. I'm talking about the driver mutation or passenger mutations. Which should be the first we have to stop, which should be the later. So this is very important questions, and as a medical oncologist, we cannot decide ourselves for this decision. This is why we are working in a team, because the scientific part is totally different and needs totally different background. So we have clinician background, they have some scientific background. So we have to combine these two. And for example, some tests are saying combine the VEGF mutation, anti-VEGF medication with the anti-EGFR mutation the anti-EGFR drug plus some MEK inhibitor, something else. 1, 2, 3, 4, sometimes 4 medication altogether. In this situation, we are looking for some case reports, phase 1 or 2 data, even the animal some tests sometimes. If we can find this at least two medication is working together and not very toxic. We are searching for this information from the literature for giving the decision. Because if we can find any clue, this combination can be not very toxic. On the other hand, we are explaining all this approach is not standard of care, and you have to accept as a patient all the possibilities, and as a doctor, we have to accept all the possible reactions. So after everybody's agree, patient and the doctor's side, we are not using the medications as usual doses as before. For example, if we are we are making a new combination, we are generally making significant dose reduction. And if we are, for example, deciding that 3 medications altogether can be helpful for the patients, we are not starting 3 of them altogether. We are starting at the first 2 medications, if she can or he can tolerate for a while. After that, we are considering adding the 3rd one with the, again, low doses. Which low doses, nobody knows. But if we are combining 2 medications, almost half dose we are giving. And if we are combining 3 medications, almost 1 out of 3 dosage we are giving. So even the dosage side should be discussable in the oncology, because all our results or our standard care comes from maximum tolerated dose. Maximum tolerated dose is not the meaning the maximum effective dose. So maybe we are using some medications overdose in the cancer, because all the studies are based on the maximum tolerated dose. Interestingly, in my experience here, even the low dose treatment can be effective if you are finding and targeting the correct mutation.
Thank you. That is you nicely shared your experience. Have you ever I think definitely would have looked into your data. How's the data, like when you looked, how much NGS has really helped? How's the outcome? How's the toxicity? What did you analyze it? How much NGS has made? How different it is from the standard of care? And how much has improved the outcome? Did you analyze anytime, or is it published? We'll be very happy to look into it. It's excellent data,
Yeah.
excellent experience what you're sharing with us.
Yeah. Yes, sure.
So I've been here for the vision for 3.5 years, and we are actually collecting everything, the survival data for the patients who were treated with targeted treatment, and we are considering to publish that, yes. So it's not published yet, but we are preparing everything, and it is at least my boss, who is also a medical oncologist, we see better response rates, better survival ratios. Usually we see some, of course, exceptional responses, not all the time, of course. There are times where it doesn't work. We are surprised, but overall it's favorable. The survival and the responses, it seems it favors these targeted treatments.
This is our experience, but not the data now.
Yeah, we are preparing it
preparing.
for a publication, and then we see it more clearly, of course. In terms of toxicity, I believe it's rare, and not because of the reduced dosages, yes. And there were some also studies recently that showing actually reduced dosages can be effective as much as the full dosages. Of course, it's going to depend on the drug, I guess, but here reduced dosage has been used for like 3 years, especially for immunotherapy and MEK inhibitors. It's been tolerated well and been effective, actually. These patients I showed, they both had trametinib, 1 milligram, not 2. Right. 1 milligram. It just has a great response.
Thank you very much. Actually, we'll be looking forward for your data because it will be guiding all of us because we know this is the path, this is the way we need to go. Only thing is the path is not clear. We need to share
Not
more,
clear.
more real world experience so that we can have collate all the data and as you rightly said, more literature comes, more confident will be to do precision oncology. Thank you very much. Thank you both of you. Wonderful presentation. It was nice to hear all your experiences. Thank you.
Thank you so much.
Thank you. There is just one more question in the chat, if I can read it out. The Dr. Narendran wants to know where do you position whole genome sequencing in the practice? Is it only when the CGP doesn't bring up any targetable alteration, or you don't do CGP whole genome at all? Like, or is it only for research purposes?
Yeah.
So we work with this test companies that have some validation in their cohorts, some FDA approval for certain indications. So other than that, we don't really do sequencing with the local labs or for research purposes. We don't really do that. So we stick to these companies who we trust and we know that they're good at their thing. And we do it for the patients, only for the clinical purposes. So we don't really use
Whole genome.
no research going on, unfortunately.
Thanks to the good tests, actually.
Yeah,
because of our tests, validated tests are answering most of our questions.
Yes.
And the test laboratory is also open for communication. We are asking our questions and they are giving the feedback. So so rarely we need or we can ask
But there
answer.
are also validated tests, the whole genome sequencing. That maybe I feel name, I don't know, but we also work those. They also do whole transcriptome and whole genome.
Yeah, if needed.
Sure. Thank you. I think that answered it well. If there are no further questions, maybe I'd like to thank you both for taking your time out and enlightening us with this amazing presentation. So
Thank you so much.
yeah, thank you so much.
Good evening from Istanbul. Thank you. Bye-bye.
Yeah, thank you. Bye. Folks, if the participants, if you have any questions to the previous session, I think Dr. Vidya is still here, or?
Yes, Arun, I'm there.
Yeah. If you have any questions on the TMB and MSI, we can ask her, or
Yeah, Dr. Vidya, I have one question. How much is the difference between testing MSI based on IHC and NGS? Now, many of the metastatic disease, we would ask for some form of NGS. If we include that as part of NGS, is that good enough? Or specifically, there are some places where we have to get an IHC done as well as an NGS done for MSI?
More than 95% concordance is there between IHC and NGS, or even PCR followed by fragment analysis, Bethesda guidelines, and NGS approach, sir.
Okay.
However, if you feel that the NGS came out as equivocal or negative, but your patient is young age and we don't see any mismatch repair mutations in the pathogenic domain, like in the previous speaker scenario, we may come across a VUS alteration, which is VUS today.
Okay.
We don't have evidence on that. But then somewhere you have a clinical suspicion that the histology is indicating that it could be an aggressive phenotype and things like that. In such scenario, it is always good to do a reflex MMR-IHC. But by and large, like what we understand, even in HRD domain today, although we do a lot of HRD on DNA, even the myriad test is on the HRD on DNA, Now there is a more evidence that is coming up, particularly with respect to the germline BRCA. All germline BRCA HRD positive cases do not respond to olaparib because at mutation at the DNA level, even though it may even see at the protein mRNA level, it may not show up at the protein level. So phenotype becomes very, very important for us, particularly when we are doing an expensive treatment, right? So even if you have any suspicion about NGS giving us an MSI equivocal or MSI low, always an MMR IHC reflex is suggested.
Okay.
Hi, myself Dr. Kunjal Patel. Is it okay to comment something?
Yes, sir.
Just wanted to, sir, know that MSI by NGS is different and MMR gene sequencing is different and MMR IHC is different. So MMR by
No.
IHC and MSI by NGS you can consider as more than 90% sensitivity. But if you are just sequencing these 4 genes, then it is not appropriate, right, in the clinical context. So
Obviously.
yes, so basically just wanted to address her questions that MSI by NGS is fine. It gives sensitivity greater than 90%. MMR by IHC is fine. It gives greater than 90%. But if you do MMR genes by just DNA sequencing, then roughly around 60 to 70% only you are able to pick up that cases. So yes, so these 3 things, these 2 are appropriate. One is not good. If you pick up, then it's fine. But if you don't pick up, then these are the 2 treatment of investigation of modalities where you should act upon. Yes, that's
So
it.
particularly
Yes,
in
sir.
the Lynch syndrome scenario, when we
Uh,
look at only the MMR genes for sequencing, we will be missing out the, there was one comment on the hypermethylation in
yes.
MLH1. We will not pick up that in sequencing. So there, IHC remains the gold standard because today we do not have many labs where you do a promoter methylation for MLH1 as a routine practice in across India. So, and also even if you get a promoter methylation positive, the ultimate thing is the protein. If you see a protein loss, that means that you're sure there is a defective mismatch repair.
Yes, ma'am.
Cool. Thank you so much, Dr. Vidya, for clarifying that. I think it was very well presented. Team, do you have any further questions? If not, we can thank Dr. Vidya, and I would request the participants to stay on a minute.
Last question, sir. Dr. Narendran here.
Yes, sir.
Just wanted to ask, when you're testing for a tumor mutation burden, you have this various panels of CGS there. Some they test in 156 genes, some they test in 256 genes, and some in 512 genes. When we go as a panel, what is the chance of missing the tumor mutation burden in a different panel? In other words, whether you go for a 512 gene or more than the 512 gene panel, you have a chance of picking up TMBs more, or is it same for all the panels? Or the minimum panel which we
Not
require to
same.
test the TMB?
Yeah, it is definitely not the same. And there are 1 or 2 studies where they have between panels to give the TMB scoring. But most often, any lab when it tries to establish, it will correlate with EXO. And as you know, the kind word tumor mutation burden, it all came with Foundation 1 early on, right? So what they did initially, they said 0.8 MB, 10 power 6 alphabets. Then they said it has to be at least greater than 2 MB. Which means to say, so the size of the panel matters. The reason why the size matters, it's not the genes, it's the size of the fraction of the human DNA which you are trying to sequence. So ideally, gold standard, I said, blueprint of your human cell. Human cell, we should imagine it's like an industry or a factory where there are many, many departments which are there. So, TCA cycle, Krebs cycle is one department. Reproducibility of the cell is one department. Then, DNA synthesis is one department. Protein synthesis is one department. So like this, you have multiple departments, and in each department, X number of genes are required to do this job. When all of them work together, then only we get the healthy cell, functional healthy cell. And how do we know this is all important? Is based on our exome, human exome, which is 38 MB in size. MB is 10 power 6. Now, not always one would do an exome. Therefore, how much low you can go? It is like it was an iterative process probably early on. How much low can you go to get to close to a value which will tell you the true somatic mutation rate? It is essentially the error rate of the tumor, that the tumor, how aggressive it is trying to evolve. So where all this tumor can create damage on the brick wall so that the wall becomes very fragile and it will start dropping off, and that's when the cell can be killed by chemoradiations and things like that, right? So all these are essentially the bricks are falling down means mutations. So where does it make, where are the regions which are vulnerable to make mutations? Mostly these are the genes which are very much important for its own function as well as the healthy homeostasis function. So that is when they came up with a set of genes. Most of these genes are already the DNA damage response, mismatch repair response genes. Everything which is responsible for a human healthy cell to remain guarded from a tumor to get onset, meaning the neogenesis process should be inhibited. All these gatekeepers, TP53 is the important gatekeeper, like this, all the other guys. So this is what is a collective set of genes which you predominantly see in 512 gene panel, 1000 gene panel across. So the more you sequence, you are getting more and more closer to the exome. That does not mean that you can keep pulling it, right? Again, affordability and value add that you get at the clinical level also becomes important. So in short, the the take home which was given again by Foundation Oneness, you have to have at least a 2 MB and above to see. That means roughly 1/20th of the total exome you need to sequence in order to get a value of TMB score close to what an exome would provide ideally. Is that answering?
Yes, ma'am. Thank you.
But nowadays, because the sequencing costs have significantly reduced, exome sequencing also is coming very, very close to a CGPI cost, not very expensive. So many labs, even in India, are adopting exome sequencing because down the line there is information with them. Today it may not be informative, like this N of 1 approaches for rare tumors. These are all possible only when you scan genes out of the box that you think are important. Unless we look at it beyond what has been recommended, we will not pick up outliers. And that happens every now and then when we do a CGP reporting with broad panels and exomes. Nearly 20 to 30% of the time we keep getting genes which are homologs. Classical example recently is a KRAS, NRAS, HRAS. We know these are all RAS family of genes. There is another gene called RAS2, which has not been very well studied, but that also has the same G12 and G13D kind of mutations, and it also functions very similar to the KRAS and NRAS in the MAP kinase pathway. So that is a rare gene, but unfortunately that happens to be mutated in one endometrial cancer patient. So exceptions are very common in our clinical practice in oncology. So wherever possible, if we are looking at a broader panel, particularly in a evolving tumor metastatic condition, there is always a very good value add that comes in when we are trying to understand the tumor biology. Sorry, it got little deviated. But the context is very simple. All these genes get mutated, and these somatic mutations are the ones which contribute to the TMB score. So that is why the more the merrier. But that does not mean you can keep going more. So you can put a stop. 500 gene is very good. 160, 170, 250 and all may or may not give you good value add, because when Foundation 1 established, they also started with 323, 324 and then they 383 and then they also have expanded their panels now. So that's how it is as of now.
Cool. Yep. Thank you. I think that was quite well explained. So to answer this question, I think it gave us a lot of clarity. So if there are no further questions, I think I would like to thank Dr. Vidya for staying with us and answering, first giving the presentation and then answering all the questions patiently. So thank you so much, Dr. Vidya. It was a pleasure having you here.
Thank you. Bye-bye. Good night.
Thank you. Yeah. The participants, if you can stay for a minute. Yeah. Dr. Arun?
Yeah, Arun, I think 8:30 now. What we can tell is like, say, I request all the participants to for the interaction. Actually, if you know, for us, these whatever the molecular basis, genetic basis, all these things are new, but we are not so well versed as we are for chemotherapy and other yeah, like PET scans, investigations, treatment recommendations. All these things somehow during our DM times we are all trained, but the precision oncology is something recently picking up, so we are not so strong. So I feel we should all come out of the inhibition, start discussing, so that each one can learn from each other, and we will make mistakes, but that's how we learn. We can ask questions, we can tell what was our experience, what was our thoughts. So I request all of the participants to interact more, and probably since it's 8:30 now, next tomorrow probably we'll have a reflection session where each one in each group one person probably will nominate, so that they will tell 5 to 6 points what they learned from the workshop. So as of now, day 1 what they learned, day 2, day 3, so 5 points on each day probably. So that way probably what was your take home points and what was my take home points, probably we will know. Probably we can learn from each other. So each group we will select one person, we'll nominate one person, probably the whoever the group in charge probably will nominate one. So during the start of the session or end of the session, probably we'll have a reflection from each group. Is that okay, Arun Kumar?
Yes, sir. I think that's great.
So
And tomorrow we have only one talk, so
okay,
we can have
so
some time for this.
yes, so I think we'll have some reflection session tomorrow for at least some 30-40 minutes. We'll discuss each other's points. We'll try to understand how we took, see, the presenter may present something, but how it has resonated with us will be totally different. How we have taken to our application, for example, circulating tumor cells. Okay, circulating tumor cells, one of the area where I am really thinking is adjuvant stage 2, how I can use the circulating tumor cells. Because stage 2 is one area where whether to give chemo or not chemo. If I want to give chemo, whether it's a capox or capecitabine. So these are the areas where I'm already wondering what to do. So whether circulating tumor cells will help me in a directing my strategy in a better way. That's how. So these are certain small nuances which we pick and we try to use it in our practices, and probably we can discuss tomorrow these things. How it resonates with our practice, how we can apply it to our practice. Probably tomorrow each group can nominate one person, or we will nominate as a mentor of that group, nominate one person, so that you can come prepared for 5 points tomorrow. So every day 5 points what you learned, you can just, so 3 days 15 points, but 10 to 15 points you can take what you learned from that particular session. Probably we can tell no hard and fast rule. You didn't learn 10 points, that's fine. For only 5 points you think that were important, you can tell that 5 points. Nothing wrong in it. Okay, so feel free. It's not an exam. It's not like all of us are contemporaries, are slightly, some may be senior, some may be junior. Only one person who will be more comfortable is Arun Kumar, I think, because his job is molecular. Okay, most of us are not comfortable. That's why we are all there in the workshop. Okay, so let's all learn from each other. So we will come prepared with some 5 to 10 points what we learned tomorrow for the session. Thank you. Thank you. Over to you, Arun Kumar.
Thank you, Dr. Arun. I think in the interest of time, it's already 8:30. There were a few comments about today's session not being very clear. If you want any specific topics or any points which you didn't understand, if we have time now, I can try to address it. If not, do drop a message. We'll see how best we can address that. Because I don't think we have time to go through the presentation all over again or
probably
rephrase.
they can put in the WhatsApp group what
group,
they didn't understand. Probably that alone we can address tomorrow after the reflection session. Okay.
Sure. Yeah, sounds good.
Okay.
Well, thank you so much.
Thank you all.